Today we will be presenting our video abstract on single-port robotic left retroperitoneal mass excision of a paraganglioma. To give a little background, paragangliomas are rare neuroendocrine tumors that originate from sympathetic or parasympathetic extraadrenal autonomic paraganglia. The majority of paraganglioma are sympathetic and can arise from anywhere along the sympathetic chain from the skull base to the prostate. Similar to pheochromocytomas, they often secrete catecholamines that manifest as episodic hypertension, tachycardia, headache, and diaphoresis. As they are rarely malignant or metastatic, complete surgical resection is usually curative. Our patient is a 44-year-old female who presented to us with a 2.6 cm left retroperitoneal mass. She reported a 3-year history of headache, flushing, and anxiety, as well as uncontrolled hypertension despite being on several medications. Notably, she has a BMI of 49. Her PCP had obtained a CT abdomen pelvis which showed the 2.6 cm well-circumscribed left retroperitoneal mass, as shown here, which was noted to be separate from the adrenal gland. She subsequently underwent a metabolic workup with a negative dexamethasone suppression test and elevated plasma metanephrines. Her norepinephrine level was 2.83, which is more than twice the upper limit of normal. A dotadate PET scan confirmed paraganglioma in the left retroperitoneum. Upon referral to endocrinology, she was started on 2 mg of doxazosin daily, and 4 days later was also given 25 mg of atenolol daily. The patient's blood pressures were adequately controlled on this regimen, and the decision was made to proceed with surgical excision of the left paraganglioma with the single-port robot. To do so, the patient was positioned in left flank position, as shown here. Access was obtained via a modified supine anterior retroperitoneal access. The incision should be made a little more than 2 finger breadths from the iliac crest, about 1/3 of the way to the umbilicus. Once the transversalis fascia is opened, the retroperitoneal space is entered and developed bluntly, and the robot is docked in a position that faces the patient's ipsilateral shoulder and then will eventually be turned towards the patient's contralateral shoulder as we travel along the psoas. The camera and instruments are docked. We start the case with the camera at the bottom of the screen, monopolar scissors in the right hand, and fenestrated bipolars in the other 2 positions. With the robot in place, the retroperitoneal space is further developed. The peritoneum is on the left, highlighted in yellow, and the retroperitoneal fat is on our right, highlighted in green. Identifying the psoas early is key to identifying critical anatomy. Here, the psoas muscle is highlighted in red. The lower pole of the left kidney is identified and highlighted in blue on the screen. Due to the more anteromedial position of the left retroperitoneal mass and left adrenal gland relative to the kidney, we worked anterior to the kidney. Whereas, if this were a right adrenalectomy, we would work posterior to the kidney due to the more superior position of the adrenal gland relative to the kidney. On the outside of the body, the robot will start to turn towards the contralateral shoulder as you work more medially. Working around the perinephric fat, the first landmark identified is the left renal vein. In this still shot, you can see the renal vein highlighted in blue, as well as the paraganglioma in orange. There are some venous branches from the renal vein, one of which is highlighted in purple. As we approached the paraganglioma, we notified anesthesia of potential surges in blood pressure. Venous branches from the renal vein are controlled with bipolar or with small wet clips placed robotically. At this point, the adrenal vein is identified coming off of the proximal renal vein. Upon further inspection, the adrenal vein is noted to be draining the paraganglioma. As we manipulate the mass, we are regularly keeping anesthesia apprised of the situation. We did not observe any changes in blood pressure with the ligation of these smaller venous branches. At this point, given the proximity of the adrenal gland and dual drainage of the mass with the adrenal gland via the adrenal vein, the decision was made to perform an adrenalectomy. Wet clips were placed along the adrenal vein, and the vein was cut. Immediately after cutting the adrenal vein, the systolic blood pressure dropped by about 10 mm of mercury. As we approached the cephalad dissection of the adrenal gland, we switched the camera up to provide a unique view above the mass and adrenal gland in order to completely free up the specimen. Upon completion, the robot was brought back and the specimen was extracted. The 5 cm skin incision was then closed in multiple layers. The specimen ended up being the left retroperitoneal mass and adrenal gland. The total EBL was 20 milliliters. The time from incision to skin closure was less than 3 hours. The patient had an uncomplicated hospital course and was able to be discharged home on post-op day 1. The pathology report demonstrated 2.5 cm tumor size. There were no concerning pathologic features, and the adrenal gland was not involved. In conclusion, the Da Vinci single-port robotic system has been adapted to retroperitoneal cases due to its versatility and ability to work in narrow spaces. Previous authors have described their experience using the single-port robot for adrenalectomy, but to our knowledge, this is the first description of single-port robotic excision of paraganglioma.